to introduce Jim Bradley, who's relatively recent addition to our staff. Jim is an internationally known craniofacial surgeon, was at UCLA as a professor for 15 years and joined us a few years ago, and we're privileged to have him, and I'm delighted to introduce him.
Thanks for the warm introduction, Dr. Thorne. It's my honor to be here for these educational lectures sponsored by NextGenFace. It's my goal to share with you some of our stories from our craniofacial patients. I want to give you an understanding of our surgical techniques and the proper timing of these procedures. I also want you to understand the strength and courage of our craniofacial children who undergo major procedures that are often staged. It is their desire to overcome these facial differences and have the ability to go out to the world to accomplish anything. Good morning. I'm happy to be here for this NextGenFace Zoom meeting. I'm going to be talking about craniofacial reconstruction. I want to introduce you to a few NextGenFace patients. The first one is Simo, who was born with a rare Tessier cleft. He's a 9-year-old boy born in Portugal, lives in the area with his mom and older sister. You can see he has facial asymmetry. You can see his orbits are misaligned so that one sits below the other. And he has exotropia, which means his eyes go in different directions. He wore prism glasses in order to see straight without double vision. He has a nose deformity, wide, high bridge, breathing, sleep apnea problems. And you can see here from a CT scan, he has an anomaly we call number 212 rare Tessier cleft. And that's what we're aimed to fix. We use something called a facial bipartition. You can see the bone cuts on the left, including the section we removed between the eyes. And we had to bring the face together after the bipartition so that we could then secure it in a normal position and correct his orbits. You can see him on the table with his interop view, correction of his nose deformity, and again intraoperatively then afterwards, after the facial bipartition correction after his first surgery, you can see the improvement of his eye width and laterally his nose. And this is Simo again with his action figure he drew and was made into a doll for him. He's subsequently underwent another surgery. This is our first NextGenFace patient. I'm going to talk to you about craniofacial reconstruction. There's certain diagnoses called Craniofacial Dysostosis. There's about 20 of them. Actually, there's about 90 of them, and we're going to focus on the main ones. So the treatment protocol, as I've been taught, marches from north to south, or from the top of the head down to the bottom of the face. So craniovault procedure, mid-face correction, Lefort 1 advancement. This patient has Apert syndrome, one of the craniofacial dysostosis. Now, this treatment protocol is outlined by my mentors, Dr. Kawamoto. This is the Kawamoto Fellow book. And Dr. Kawamoto on the left, Dr. McCarthy in the middle were some of my mentors that taught me these clinical protocols. But these are based on science, based on basic science. My mentor, Bernard Sarnat, and I published this book, which goes over this, and this is the reason we have these protocols. This is Dr. Sarnat, was kind enough to generously donate a chair. So these clinical protocols are based on science. The craniofacial dysostosis is a spectrum of phenotypes. You can see all the different diagnoses. Basically, pterocephaly, tall head, brachiocephaly, broad forehead, and mid-face hypoplasia. So to look at all these, they have similar spectrum of phenotypes and common features. So we're able to use protocols. This is the same patient from birth to adulthood. You can see we start at the top with the craniovault remodeling at age 3 to 6 months, then the mid-face, later on in mid-childhood to advance his mid-face, and then finally down at the lower face, orthognathic or jaw correction. And you can see the correction as we go, depending on his growth. So the skull was done in the newborn, the mid-face, mid-childhood, and then the orthognathic or jaw surgery. So as an infant, they can have different craniosynostosis. You can see the triangular trigonocephaly, the boat-shaped scaphocephaly, and oblique plagiocephaly. So if you have that trigonocephaly, the correction has to do with them age 3 to 6 months, and you correct the forehead to allow the brain to expand so it's not constricted and get a result like this. Now, if you have coronal synostosis, that's one side. You can see the flattening with the red arrow and our virtual plan expansion. So you have these colored ideas of how you're going to do the reconstruction. The yellow goes to the yellow pre on the left, post on the right, and you can see the advancement. So when you have coronal synostosis on one side, you have to plan an advancement to gain symmetry and release the brain that's being constricted. Most of the patients have brachycephaly, which is bilateral coronal synostosis. You can see the diagnosis and the percentage that have that. So to correct that, it's a little different. These are the osteotomy lines, the frontal craniotomy, the supraorbital bar, all that get advanced to correct the flattened forehead. We advance it almost 2 centimeters. We flip the side that's bulging out, and then we reduce the height. All those things are done in the operating room, and you can see a large advancement. To decrease the dead space, we lower the height, and that's necessary to overcorrect so that later on we don't have to do as much of the forehead correction. So at mid-childhood, then we have to focus on the face. Often we have to fix hypertelorbitism and mid-face retrusion. So we devised a procedure that has facial bipartition combined with monoblock distraction. We call it the Roman arch procedure. The facial bipartition we had seen before with SEMO, and you can see how the orbits can be corrected. In this case, the immediate post-op view, you can see not only we're correcting the orbits, but that bunch skin, we call the K-stitch after Kawamoto, goes away with time to create our correction. So monoblock distraction is combined with this. In this case, this patient with Antley-Bixler syndrome is trach dependent, having breathing problems, ocular problems, but after the advancement, after the midface is brought forward, the trach can be removed. So we're combining the facial bipartition and monoblock distraction in the Roman arch. So it's called that because based on the Roman arch stability in the center, we're pushing forward the arch of the face. As you can see here, we curve the face to correct the flatness. We provide a keystone for fixation in the middle, and then our devices laterally push the face forward, so we need that stability. We had to study this, so we used patients that had the procedure. The intraorbital distance was studied, and you can see it preoperatively 38 down to 20 in follow-up. And we looked at the intercanthal distance between the eyes and the correction from 48 millimeters to 35. And finally, the brow distance. So all these measurements were done, and we can see the improvement of the brow distance, interocular distance. Now, laterally, we're also advancing the face. So we had to study this, and we found an average advancement about 16 millimeters with a mild relapse of 2 millimeters. You can see this at the forehead at the top. You can see this at the mid-face in the middle, and down below at the maxilla. So we realized that this was effective. Now, we're talking about patients with craniofacial dysostosis. We treat them from birth to adulthood. At 3 years of age, frontal orbital advancement is done. At 7, monoblock advancement. 10 years before Lefort 3, that's the midface. 12 after Lefort 3, 15 before Lefort 1, that's the jaw, and 18 after Lefort 1. So you can see following the patient from beginning to end is necessary because of the growth. Here's the lateral view of the same patient, again, with the primary surgery at infancy, mid-face surgery, and then orthognathic surgery as an adult. You can meet Rokas. He's our next-gen patient with craniofacial microsomia and a cleft. When he was brought to us, some people compared him to Augie from The Wonder, although he has a different diagnosis. His diagnosis is craniofacial microsomia, but also has a cleft. So he was missing his bone on the right side. We call this a Brzezinski 3 mandible. It was too small to be able to stretch that bone, so we had to replace it with a rib here intraoperatively, a rib graft, and we also did fat grafting to his right cheek. You can see the rib graft replacement in this CT scan, and that's how it advanced him, and then the fat grafting. So that was not just for cosmetic or aesthetic reasons, but it actually helped his airway. You can see on the left, this is his tongue base collapsed to his throat, and then afterwards, that's an open airway, and that's what we wanted to achieve in him. So this is his correction, And then Rokas just sent us a holiday card. You can see he's with his sister overseas, and he comes back to visit our team. And he will, again, have another procedure, but he's doing quite well. Craniofacial microsomia, what Rokas had, often requires mandibular distraction and sometimes fat grafting. You can see before this happens, the asymmetry. After the distraction, the chin point moves over, and then after fat grafting, then we can get more symmetry. Often ear reconstruction is needed, and Dr. Thorne will get into how total ear reconstruction can be done. Mandible distraction is something where we can grow bone. This was pioneered by Dr. Thorne, who's on our team, McCarthy and Karp. And you can see the vertical vector we can have or the horizontal vector. With craniofacial microsomia, a vertical vector is preferred. This patient is older, but still with craniofacial microsomia. She had a double jaw procedure to correct her asymmetry. You can see her midline's straighter, but still her orbits are off. So we had to do an orbital box osteotomy to bring that orbit down to correct her eye. But you can still, she was flat in her face, so we had to fill that with a free flap called an IMEX flap because it was too much just for fat grafting. Now, craniofacial microsomia should be differentiated from Treacher colons, which is bilateral and symmetric. And you can see this patient from pre-op to post-op. We had to correct the cheekbone areas, the eyelid areas, and the mandible. Those are all involved with Treacher colons. In addition, they can require ear reconstruction. So there's different severities to this. This malar reconstruction or cheekbone reconstruction does require bone grafting. It also requires what we call an eyelid switch flap. This is an involved procedure where we're borrowing bone from the head, reconstructing the cheekbone to correct the satin eye appearance of the Treacher colons patient. This is Jan. I want to introduce you to this patient who is probably the largest frontal nasal encephalocele I've dealt with. The interorbital distance was 81 millimeters. You can see by the CAT scan, he actually had viable brain herniating between the eyes, and we had to bring those eyes together and bring up the brain. So we used a ventriculostomy drain. We did something unique called contraction of the orbits. So we used a distraction device in reverse to correct that. We did it halfway on the table. You can see the left. On the right, we finished that afterwards to bring him from 81 millimeters all the way down to a normal orbital distance. After that was done, we did soft tissue correction of his cleft lip, his nose, his palate with a pharyngeal flap. And this is a child who came in basically in a stroller, not talking, drooling, and was looking from one side to the other until his correction and was basically playing like a normal child afterwards. This is a smaller but still a Frontonasoethmoidal encephalocele, smaller lesion, but you can see this is not normal brain herniating, but a glial mass that has to be taken care of. When we correct this, we need to correct everything in and around the medial canthus, the medial orbit, the nasal maxillary process. The procedure we use is called a hula procedure. We do a limited craniotomy, we split bone, we do correct the orbit, correct the nose, and move the bone. So this is the bones then moved in place. We're translocating the orbits back into normal position, translocating the nose, doing a bone graft to the nose to do the correction. When the skin's damaged like this, we have to do it externally and internally to remove this. So you can see here the correction of the encephalocele, the bony reconstruction, and a similar patient. All these are slightly different, but we have to correct both the medial canthus, the nose, for the reconstruction and repair the herniation. When we do our procedures when we see them as a team, we're looking at patients from infant to adulthood. This patient came as an infant with a critical airway. This patient was diagnosed with Nager syndrome. You can see the small lower jaw. You can see, imagine the tongue base sticking to the back of the throat. So we had to do what's called neonatal mandibular distraction to bring out the lower jaw, to correct the tongue base, and to save the child from a tracheostomy. Often we have patients come in, and then could be more life-threatening emergencies. In this case, this child had an expanding cystic mass that at 2 weeks was growing day by day, so we had to urgently decompress this mass in the operating room. You could see imaging showed that the cyst was filled with CSF fluid. You can see the distortion of the bones. And you can see afterwards we did decompression, then you could really see the deformity of the face that had to be addressed. We did adhesion surgery, which can be similar to lip adhesion followed by a formal cleft lip repair, and then required secondary reconstruction after this. So this is an infant that required urgent care just to get to the place where we can then provide definitive care. This patient mid-childhood, this is actually not a child from third world country, child that's here locally. Functional problems, tracheostomy since birth, G-tube dependent, speech problems. We did one procedure to correct a lot of this Tessier cleft. So she was born with what we call a 4-10 cleft and a 6, 7, and 8 cleft, so all on the left side. So to do this, we did an eyelid switch flap medially, transnasal wiring. We did a cheek advancement and correct the nose, and the patient was reconstructed. After the secondary reconstruction, trach was removed, G-tube was removed, and she's ready for her next round of surgeries. I'm going to finish with a patient that you're going to be introduced by our director, Barbara. So this is Taina, who's born with Cruzon-like and cleft lip and palate. I'm going to focus on the medical aspects. She underwent hypertelorbitism correction and correction of mid-face hypoplasia. You can see with the planning, we had to remove the red bone and bring her orbits together. We had to then correct these on both sides. Again, she's at skeletal maturity, so she's been followed until this time. Now you can see, in addition to correcting with the hypertelorbitism, we want to do a mid-face advancement. That's done with an internal distraction device. And you can see how much the face is brought forward to give that correction of her orbits, nose, and her upper jaw. This is our NextGenFace team, so all these patients that come in get a full evaluation, including the images. We see them as a team. This is pre-COVID, but we're seeing patients safely now, and we can basically have experts from each of the subspecialties weigh in so that nothing is missed, so that all the details are addressed at each time point that they're seen, again, infant to adulthood. You can now see how each NextGenFace team member evaluates the patient. Each team member has their own expertise. Each team member has their own different specialty. And each team member will give their input. Then together, we will formulate a plan, and this plan will be shared with the patient, the family, the primary care physician, and the referral. In sharing stories of our NextGenFace patients today, I hope you gained an understanding of the timing and techniques of craniofacial care. All of the members of NextGenFace, including myself, are passionate about comprehensive care for our patients. Thank you so much for your attention today.